Hi, I'm Helene Barrera,
I'm Blake Freeman.
I'm Justin Ehly.
and this is our Capstone project on government policy and COVID-19 hospitalizations. So the coronavirus, as you probably know, began in late 2019 and spread to the US in January of 2020. It's had a global impact on all aspects of life. The US government began rolling out policies starting in March, and states began reporting data related to COVID-19 in March as well. However, we chose to start our analysis in July 2020 due to the incomplete and unreliable nature of the data prior to that time. Strain on inpatient hospital capacity is not new. It's only been exacerbated by COVID-19. Hospitals typically aim to maintain around an 85% occupancy rate in their inpatient and ICU wards. This is so they have enough beds for emergencies without healthcare costs shooting up due to empty beds. However, other factors that they use to maintain their baseline occupancy is outside of the scope of this study. We want to focus on how COVID-19 has pushed occupancy rates to the limit. We used publicly available data sets to predict COVID-19 hospital bed occupancy. We also used these models to determine the most impactful government policy features that could reduce inpatient hospital bed utilization. Our goals for this were to have a simplified and interpretable model for predicting COVID-19 hospitalizations, to find future importance of government policy decisions on hospital occupancy, and to possibly help alleviate hospital capacity issues by being proactive with particularly effective government policies. We use the Oxford Government Response Tracker data for most of our government policy features. The data was collected on a weekly basis by volunteers internationally. The policy features include things like mask mandates, school closings, stay-at-home orders, as well as vaccination policies. Our COVID hospital occupancy data came from healthdata.gov, which was collected at a facility level and aggregated by week. We also included data from the Immunization Action Coalition website to add dates for FDA authorization of different COVID-19 vaccines. And lastly, we use CDC data to add flu and vaccination data to the model. Once our data sets were all imputed and merged, we had 62 weeks of data for each of the 50 states and Washington, D.C., plus 34 features. Now I'll turn it over to Blake for discussion on our EDA.
Yeah, talking about our EDA process here, just kind of the start of it. Let's just start here. We're just talking about a time series looking at total COVID patient beds versus total inpatient beds. Just kind of looking at the time frame here, as you can see, we have definite spikes here. So there's a definite issue and something that we were trying to look at, evaluate and predict. Moving on from this point, when we were looking at a lot of our features, we actually took a correlation matrix and actually looked at it to remove anything that had 90% correlation or higher, so that we could have a little bit more feature reduction. And at that point, we wanted to actually look at the features more individually by state level. So from this, we were just looking at each state level, going through the features that we expected to have importance in our modeling. We looked at information to see variability by date to help create the hypothesis that which features that might or might not be important within our model. Each of the features we looked at ranged from having no action, which is the white, to having major action, which would have been the dark blue. You know, for example, this one is just school closings. Next, we're going to kind of look at the cancellation of public events. Then we're looking at the restriction on gatherings. And this one's just looking at stay-at-home requirements that are being put into place. And this one, for example, didn't have a lot of variability versus the previous ones we've been taking a look at. And we're looking at testing policy. Again, a lot less variability. To vaccination policy. which has a lot more variability even to each, the state level. Ultimately, just as an example, there were several unimportant features. Public information campaigns, though might be important features in the general sense, there is no variability here, so therefore we wouldn't see a huge impact in our correlations or expect to see any. After this, I'm going to turn this over to Justin to talk a little bit about the models.
Thanks, Blake. So we wanted to use models that were highly interpretable. So we started out with just a basic linear regressor. Again, just to reiterate how interpretable those models are. If you think about it, it's essentially y equals mx plus b, or y equals beta naught plus b1 times x1, etc. And to interpret those models, you simply say, okay, if everything else is held constant, then the x1, the weight of beta 1 is what determines how important x1 is to the model, right? But we didn't want to be that simple. So to get a little more advanced on the modeling, we looked at a random forest regressor, I should say. Again, highly interpretable, because the way random regression works is it looks at feature contributions from each tree, and then it averages all those trees' feature contributions across all the trees in the forest. And then we can take those average weights and use those to determine what feature importance is. And then ultimately we tuned our random forest model, just making granular adjustments to each of the parameters. So the next thing we wanted to do was, once we had our random forest tuned, we wanted to see how well it generalized. And the way we did that was we used an 8-week sliding window. So essentially what we do is we take the first 6 weeks and we predict the next 2. We slide the data forward a week, use that 6 weeks, predict the next 2, all the way through the model. We take a look at the R-squareds from each one of those different windows at a time. We average them, and that tells us how well the model is generalizing. We also take a look at the plots on that, so we can kind of see where the model might be struggling, and if there's any additional tuning parameters we may need to consider. So this is a graph of our results of our top 15 features, and I just wanted to show you that there was quite a bit of difference in terms of what was actually correlated with COVID-19 patient hospitalization and what wasn't. So let's take a deeper look into a couple of these individually on the next slide, where you can actually see what those were. So if we take out the top 2, which we can expect to be highly correlated with COVID-19 patient hospitalization, number 3 contributed 4% in terms of weight to the model. That was just people receiving the first dose of the vaccine. So obviously vaccines had a high correlation with COVID-19 patient hospitalization. We look at number 4, it had a 1.9% weight. That's government containment closures. And number 5 had a 1.5% weight. And again, that was the vaccine policy was actually a cost weighting measure. It wasn't actually whether or not how strict the government's vaccination policies were. So it's interesting that popped up. But if we really want to conclude, in summary, we can say that vaccinations, and that's all the different vaccination requirements or vaccination determinants that we had in the model, combined had a 6.2% weight. And second, all the social containment measures combined had a 5.1% weight, right? So it was just something really interesting to see outside of hospital data directly that highly correlates with itself, which government policies and outcomes of those policies, for vaccinations, for example, actually had the highest correlation with people that were hospitalized from COVID. And then lastly, we think it's important to talk about the ethics of a study like this. Yes, we did use fairly simple models that in itself can lead to people distrusting the science, but keep in mind COVID-19 did become very politically charged. And not only was it a simple model, but we didn't have 100% R-squared or 100% accuracy in any of the models. And it's real easy for people that want to be able to attack the findings and the statistical significance by simply saying, well, it's not 100% accurate, So that other 15 or 20% inaccuracy gives us good reason to just not take, the science at face value. And that is it.
Thank you.
Thank you.